Good evening, everyone. So today's topic will be on normal anatomical landmarks, and we are going to restrict it to the intraoral anatomical landmarks in this chapter. Okay. So in this chapter, we are going to learn about what is normal to appear in a radiograph. What are all the anatomical structures which appear on every radiograph, and only if you learn what are the normal structures or the anatomical landmarks, you will be able to diagnose or identify something apart from that. That is your pathology. Okay, so for your convenience, I have divided region wise both for the maxillary and the mandibular. Okay, so look at the pictures and please understand. So let's begin the chapter. So, a tooth consists of enamel, which is radiopaque, dentin, which is also radiopaque but lesser than the enamel, cementum, which is also radiopaque but lesser than the enamel, pulp chamber and root canals are radiolucent structures. Then you have the investing structures. They are the cancellous bone, which is made up of both radiopaque and radiolucent. Lamina dura is radiopaque. Cortical crest of the alveolar bone is radiopaque. It looks, it takes the shape of a knife edge anteriorly and they are flattened posteriorly. Okay, so these are the things. And now, when you shoot a radiograph region wise, okay, this is for learning of the normal anatomy. We shall first list out what are all the normal anatomical radiopaque and radiolucent landmarks in the maxilla and the mandible, and then one by one. So, these are the anatomical landmarks of the maxilla, radiolucent landmarks. Okay, the first one is nasal cavity and nasal fossa, mid-palatine suture, incisive foramen, soft tissue shadow of the nose, maxillary antrum, orbital opening of the nasolacrimal duct, nutrient canals. They are seen as grooves in the maxillary sinus as well, and lateral fossa. Now, radiopaque landmarks, there are 13. Nasal septum, floor of the nasal cavity, anterior nasal spine, inferior nasal concha, floor of the maxillary sinus, inverted Y line of Ennis, malar process of the maxilla, nasolabial fold, maxillary tuberosity, coronoid process, pterygoid plates, hamular process, and septum in the sinus. Okay, coming to the anatomical landmarks of the mandible. What are the radiolucent landmarks here? Lingual foramen, mental foramen, mandibular foramen, which is seen in the ramus, mandibular canal, submandibular gland fossa, vascular channels, pharyngeal air spaces. They are more seen on the lateral oblique and other extraoral views, and bone marrow space. Now, radiopaque landmarks in the mandible, they are genial tubercles. They are more clearly seen on the occlusal views, mental ridge, borders of the mandibular canal, that is tram lines, external oblique ridge, internal oblique or mylohyoid ridge, lower border of the mandible, antegonial notch, condyles, coronoid process, and the sigmoid notch. Okay, so in this chapter, intraorally, we are taking a intraoral periapical radiograph very commonly, right? So let us first concentrate on all the landmarks which you are able to appreciate on a IOPA radiograph, okay? And subsequently, we will be dealing with what are the landmarks which are also visible on an occlusal and the extraoral separately. Okay, so coming to maxillary anterior region, the radiolucent landmarks. First one is the nasal fossa. It's a W-shaped radiolucency, may be misinterpreted as soft tissue tumor. So, if there is any confusion whether it is a normal or a pathology, the use of tube shift technique is used, in which if the radiolucency is in place, it indicates a pathology. If the radiolucency moves, then it indicates a normal anatomical landmark. So, how does this look? The nasal fossa. Can you see this picture of an X-ray? This radiolucent structure, which is denoted by the arrow, is the nasal fossa. It is the W-shaped radiolucency. Okay, and it should not be misdiagnosed as a soft tissue tumor. So, whenever we take a tube shift technique or the slot technique, if it is a pathology, it will move definitely on the position of the cone. Okay, as the position of the cone moves, definitely if it is a landmark or a normal one, it will move. Whereas if it is a pathology, it stays put in the same location. That is the way of differentiating. Okay, so this is how a nasal fossa looks like. Next one, incisive foramen. It is the opening in the midline of the palate just posterior to the central incisors. It gives passage to nasopalatine artery and nerve. It can be misdiagnosed as dental infection or cyst also. Okay, can you see this radiograph over here? The arrows which are denoting over here, no, this one, this is the incisive foramen over here, the radiolucent finding. So the incisive, whatever the nasopalatine arteries and nerves, they pass through this area. Okay, and because there are cysts in the maxillary anterior region which can mimic this radiolucency, so it should not be confused. A proper history and, if required, alternate radiographic methods are used to rule out the doubts. Okay, next, median palatine suture. First, look at the diagram. In this diagram or in this radiograph, there is a suture. Suture means what in anatomy? This is if this is the midline, and then this is one part of the bone. This is one part of the bone. They are forming a suture. Suture is the um, what do you say? The placement of two equal halves of bone together, right? And in the midline over here, there are this arrow denotes the mid palatine suture. They are more nicely visualized in an occlusal radiograph, which we will be learning again. So, what is a mid palatine suture? It is the line down the center of the maxilla where embryonic palatal shelves joined at the midline to form the hard palate. Can be misdiagnosed as fracture line or fistulous tract. So, what do you do to differentiate when you are in confusion? See, always a fracture line will be accompanied by history of trauma, and it will be an irregular radiolucent line, and it will not be bordered by two radiopaque lines. If you can see, there is a radiopacity on both sides of the suture, but in between there is a thin line of radiolucent line running over here. Whereas if in a fracture, it will be without this radiopacity in its borders, plus associated with a history of trauma as well. Okay. So fistulous tract, if there is a periapical infection, if a sinus and a fistula is formed, then we apply radiopaque material through the lesion and tortuous course of the tract can be observed. This means what? Sometimes we use gutta percha sticks to find out that from where the sinus tract is being formed or the fistulous tract. So this is one of the method of diagnosing a fistulous tract and not getting it confused with the mid-palatine suture. Okay, so D, incisive fossa. It's also called as canine fossa. It is the indentation between the roots of central and lateral incisors. When is it called the canine fossa? It is called canine fossa when there is an indentation between the lateral incisors and the canines. So, to avoid misdiagnosis, other side radiograph shows this is between the central incisor and lateral here. So this is your incisive fossa. If the same thing happens between lateral and canine, it will be the canine fossa. Okay. Nasopalatine canals. If increased vertical angulation is used, they may appear as projections of maxillary incisors. There are thin radiolucent canals over here, which are the nasopalatine canals, denoted by the black arrow over here. Okay, so that completes our radiolucent findings, which are very common to find in IOPA radiographs. Now, coming to radiopaque landmarks in the maxillary anterior region. Okay, first one will be the median nasal septum, thin wall of bone in the midline of the nose that separates the right and left nasal fossae. Increased density may denote mesiodense and retained tooth. This is the maxillary anterior section. over here together in the in between, and this forms your median nasal septum. This is a bone, the radio opaque structure. Okay. Anterior nasal spine. It is the triangular protuberance of bone that extends forward from the inferior aspect of the nasal cavity at the midline. Can you see this one? This is the anterior nasal spine, and it can be a triangular protuberance of bone, okay, in this place. But sometimes the density of this, it can be misinterpreted as retained root, odontome, impaction, or a foreign body. So alternate radiographs or method of radiograph need to be differentiated to avoid the misdiagnosis. Nasal turbinates. Opacity. So they are not exactly bones, they are thick cartilages. So they look like this. If you can see the white cartilage, soft tissue of the tip of the nose appears as a radiopic shadow superimposed over incisors or root. Uniform opacity with sharp body. There is one V shape where I'm moving the cursor over here. There is a V shape radiopic border which is superimposing with the roots of the maxillary anteriors. This is nothing but the shadow of the tip of the nose. The soft tissue is fallen like that. Okay. Now, coming to maxillary canine region. What is here? Here, mostly you are able to see the nasal fossa, which is already described. Incisor fossa is also seen, that is also described, the canine fossa. And apart from this, you are able to see the a part of the maxillary sinus, which will again be more better visualized in the premolar molar region. Okay, so in the canine region, mainly you are able to see the maxillary sinus, the one to the left over here. Okay. Now, coming to maxillary canine region, radiopaque landmarks. It is called as inverted Y line of Ennis. They appear as inverted Y-shaped radiopaque lines separating two radiolucent areas, that is nasal cavity and maxillary sinus. So, the border, the radiopaque borders of the nasal cavity and the maxillary sinus, they look like a inverted Y shape over here. This one and this one. Okay, this is called as the Y line of Ennis. So, coming to the maxillary premolar molar region, radiolucent landmarks. What is main over here is the maxillary sinus. So, it is the most important structure, occupies the greater part of the maxilla and appears as radiolucent area. It is not completely visualized in IOPA. The radiopaque line represents the floor of the sinus. Okay, over here. See, this is the canine, first premolar, second premolar, and first molar. So this huge radiolucency here, this is the maxillary sinus. And the radiopaque line over here, this is the border or the floor of the maxillary sinus. That is why whenever we perform a endo treatment or an extraction for any of the upper premolar and molar, one tends to be more careful because of the risk of sinus perforation in this area. Okay. Then maxillary premolar molar region. What are the radiopaque landmarks? First one is the malar bone. This is where the zygomatic bone attaches to the maxilla. It appears as well-defined radiopaque area superimposed over maxillary molar roots. It can be misdiagnosed as impacted teeth or foreign bodies as well. Okay, and this looks like this. There's white color over here, white color arrows. This is the malar bone. It is usually present in the area of the zygomatic bone and the maxilla. Okay, it appears on a radiograph like this and more proximal to the maxillary first molar. Okay, so regions posterior to maxillary third molars. Okay, this is only the molar region and beyond that. Okay, so radiolucent structures will be the hamular march. It is found between the hamular process and the maxillary tuberosity. You have a good labeling over here. In this radiograph, we are able to see the first molar doubtful over here. Okay, so consider this as the first molar, second molar, and this is the third molar region. But here there is no third molar, but you are able to see the hamular process of the sphenoid bone. Okay, the base of the skull, and maxillary tuberosity is this one. So in between that there is a shadow or the notch which is found is called as the hamular notch. This area. Okay. So, regions posterior to maxillary third molars, radiopaque structures. What are the radiopaque? That was a radiolucency. So, radiopaque structures, we have maxillary tuberosity, in which it is the rounded bony eminence just posterior to the most distal molar. It, although the hardest structure in the maxilla, it contains spongy bones. So, while removing of third molars or any tooth in that region, one needs to be very careful while applying pressure because it can break. Okay, so in this radiograph, if you can see, the arrow mark is denoting the rounded bony eminence beyond the last molar. This is the maxillary tuberosity region. Okay. Hamular process. It is the finger-like projection of bone distal to the tuberosity. It is called as hamular process of the sphenoid bone. Okay, there is a sphenoid bone which is there at the base of the skull. So whenever X-ray of the intraoral beyond the third molar region, when the film is placed more distally and taken, even this hamular process also forms. It also falls in the radiographic picture. Okay. Next, coronoid process of mandible. It may appear when the mouth is opened as a triangular projection located in the area of the tuberosity. Okay, this is the tuberosity, and can you see a projection like this? The arrow, the black arrow. Okay, so whenever the mouth is opened, okay, while taking the radiograph and placing the film very posteriorly, what happens? The triangular projection which is in the mandible falls in the maxillary radiograph. That is the coronoid process of mandible. Okay. Now coming to anatomical, so that completes the maxilla intraoral anatomy. So coming to the mandible part, anatomical landmarks of the mandible, radiolucent landmarks. So in the anterior region, okay, we'll go region by region. There are interdental nutrient canals. They contain blood vessels and nerves. They appear as radiolucent lines of uniform width, and sometimes it exhibits radiopaque borders also. It should not be misinterpreted as fracture lines. So let's see in the picture and understand this. Okay, this is the lower anterior. Okay, the centrals, laterals, and a bit of a canine is seen here. So can you see the small foramen over here with a radiopaque border in this? All the four arrows are indicating towards this. So here it can appear as radiolucent lines of uniform width and sometimes exhibit radiopaque borders. Okay, so whenever they appear as a line, it should not be misinterpreted as if it is a fracture line. Okay, that's when you need to know that how exactly a fracture line looks, how important is the clinical history, and if required, alternate radiographs or even a tube shift technique may help. Okay. Next one, radiopaque landmarks. Okay, that was radiolucent. Now coming to radiopaque landmarks, they are genial tubercles. They are small bony spines formed on the lingual aspect of the mandible, adjacent to the midline at the attachment of the geniohyoid and genioglossus muscles. How do they look like? Over here, I have taken three radiographs for reference. Okay, here genial tubercle. Okay, this is a mental ridge over here, and can you see there are some radiopaque mild thing over here? Look at the second one. The white arrows are pointing towards in this area, the thin ones over here. Okay, these are your genial tubercles. Okay, and here is where on the lingual side, inferior side, the genioglossus and geniohyoid muscle attachment is present. Okay. So, coming to mental ridge, elevated ridges of bone located along the anterior aspect of the mandible, also known as mental tubercles, and they fuse at the midline to form the mental protuberance. What does that mean? Over here, the first radiograph, this is the mental ridge. Can you see one faint triangular shape over here, this area? And it is marked by the white arrow here. Here it is not that clear, right? So it depends on patient to patient also. Okay. Some cases it may be very dense, some cases it may be little vague. Okay. So that is mental ridge. And they cause a mental protuberance. When you see the specimen of a mandible on the lingual side, you can see there is a small elevation in that area corresponding to the lower anterior. So that is your mental ridge. Okay. Coming to premolar region, what are the structures over here? The radiolucent ones. Mental foramen is most important structure in this region. Mental nerve and vessels pass through this foramen. Identify the periodontal membrane or the periodontal ligament space to see if it's confluent with the radiolucent opening. Okay. First radiograph and second radiograph, you can see it is falling below the second premolar area. Okay, in some cases it will be in between first and second lower premolars. Over here, there's white arrows denoting it. Okay, and here this is the molar. Now, whenever there is a position, okay, by nature every patient has the different placement of the normal anatomy itself, right? So now, if there is a radiograph wherein you are having a doubt whether it is a mental foramen or it is some periapical radiolucency, what do? You just have to make sure that you read the periodontal ligament space over here. Please follow the cursor which I'm showing here. This is the periodontal ligament space over here. Okay, this is normal. Okay, so if the radiolucency is over here, the mental foramen, it's very clear, right? It is not continuing with the PDL space, so it is definitely a normal anatomy. Whereas if you can see the distal root over here, if you can see this radiolucency, it is somewhat merged with the radiolucency periapically, right? And more than that, if you can see the crown of the tooth, there is a filling, there is a big carious lesion over here. So all this will indicate towards a diagnosis of a periapical abscess or a periapical cyst or other things. Okay, so these are the things which you have to keep in mind whenever you are confused with the pathology. And this one, look at the root and look at the tooth and the PDL space. Clear? Coming to next, molar region. What are the radiolucent structures here? Mandibular canal, very important. Inferior alveolar canal, and artery passes through this canal. So whenever you are giving an LA block, you need to have these anatomical landmarks on your fingertips. Okay, and this is what is going to help you when you give your LA block to palpate it and then put your injection at the appropriate place. All right. So this extends from the mandibular foramen on the lingual aspect of the ramus through the body of the mandible under the roots of the molar teeth. Okay. The left picture is of a edentulous patient. There is no tooth. Okay, no teeth at all. And can you see this canal over here which is passing through? And there is a, the canal is radiolucent, okay, but there is a faint line of radiopacity which is bordering it, right? So this is your mandibular canal, which in the this one, what do you say, in an edentulous patient. Whereas in a patient with tooth, here there is a tooth present, and this white arrows, if you see, it is in close proximity to the roots of this molar, right? So one has to be really careful while extracting the lower tooth because of the risk of damage to the inferior alveolar nerves and vessels, and especially if the radiograph is giving a proof that the canal is more in proximity to the roots of the tooth. Okay, so this is where normal anatomy you have to learn and apply in your clinical situations. Okay. Next, Submandibular fossa, directly below the internal oblique ridge is a depression in the lingual aspect. You can see this area, or better come to the second one. This is the molar here, okay, and then here there is a arrow mark which is there, okay, and this is the internal oblique. This is the external oblique. We'll learn about it. Okay, so internal oblique ridge and external oblique ridge, wherever it is there is a slight depression on the lingual surface of the mandible. So that is the submandibular fossa. Similarly, here the shadow, if you can see, okay, this is the submandibular fossa. Next, radiopaque structures, lower border of the mandible. The lower border of the mandible is the thick cortical plate that forms the lower edge of the mandible. The solid thickness of bone along the inferior border of the mandible is seen in the radiograph as a uniform, wide radiopaque band at the margin of the mandible. Okay, so can you see this? This is the lower border of the mandible. When you place the X-ray film really deep and you are able to shoot the X-ray, so you are able to see everything: mandibular canal, submandibular fossa, and your inferior border of the mandible. This white lines over here. This is for posterior. The image on the right is showing it for the anteriors. Okay, this one. So, internal oblique ridge, it is an eminence of bone extending along the lingual aspect of the mandible, okay, appears as a radiopacity band or a radiopaque band extending from the terminal molar region to the premolar, okay. Can you see this radiopaque line here towards which the arrows are pointing out? Okay, they've come from the molar to the premolar region, little bit in the front, okay, and it is extended like that. This is the internal oblique ridge. External oblique ridge is what? The something which is there on the outside, okay. So it is a continuation of the anterior border of the ramus, passing downward and forward on the buccal side of the mandible. Appears as a radiopaque line, which usually ends anteriorly in the area of the first molar. Okay, can you see this? This one, the radiopaque line over here. Okay, so about this, just imagine a picture which is above this. This is the ramus. So continuation of the ramus downward and forward and ending anteriorly to the first molar. Okay, the region, and this is the external oblique ridge. Okay, this is how it looks. So we have now learned that how anatomical landmarks. What are they? First of all, clinically, and on a radiograph and a clinical application, and these are the landmarks which you are able to very commonly see. Okay, so these were the intraoral anatomical normal landmarks. So we shall discuss the MCQs related to this. Okay, so question number 1: which tooth structure has a radiographic appearance similar to the bone? Answer is B, that is dentine. Okay. Then, second question: which causes cervical burnout? Okay, that is a D, decreased X-ray absorption. Cervical burnout is nothing but whenever it mimics a class 2 cavity, or there will be the CEJ, right? This thing at the junction, it looks like there is a cavity present. That is because over there the X-ray absorption is not that good. So because of that, they mimic a cavity, but they are not. So clinically, it needs to be checked also. So second question, answer will be D. Third one: which occurrence resembles a periapical lesion? Okay, what are they? The answer is D. That is dental papilla bounded by a bony crypt. Whenever a tooth is emerging or it is going to erupt, it looks like it is formed within a cyst. So that may mimic a periapical lesion, but again, the age and the clinical appearance and the clinical observation needs to be taken into account before reaching any conclusion. So, question number 3, answer is D. Fourth one: which development occurs with the aging process? The answer is D, that is deposition of secondary dentine. Fifth one: which supporting tooth structure appears radiopaque? Okay, that is first one, lamina dura. Okay, what happens when there is a loss of lamina dura? It means there is a periapical lesion which is deep enough. Okay, so sixth one: which best explains the normal radiographic appearance of the alveolar crest cortical bone. That is A, eggshell effect. Seventh one, which describes the X-ray beam in relation to the radiographic appearance of well-defined radiopaque lamina dura. Answer is D, directed straight through a relatively long expanse of the structure. Okay, this is a lamina dura. That is seventh one is D. Eighth one, which structure appears as the radiopaque outline of an extracted tooth? Eighth one, answer is A, lamina dura. See, sometimes whenever a recent extraction has been done and you take a IOPA, it looks like there is a well-defined outline of the tooth root. It is basically because of the lamina dura, which takes some time to resolve. Okay. So ninth question, the radiographic appearance of a wider, denser lamina dura may indicate a tooth that is ninth, that is B, that is heavy occlusion. Okay, whenever there is a occlusal trauma or there is a heavy biting force, the lamina dura will be more denser. So answer for ninth question is B. Tenth one, which might the clinician deduce if the lamina dura is visible around a maxillary molar. Okay, that is C, absence of a disease. Normally, if a tooth is healthy, the answer is C for 10th question. Coming to 11th question, the clinician should consider all except one when establishing a diagnosis. Which one is the exception? Okay, the exception will be C, previous medical history, because we are taking a radiograph. So intraoral signs are important. Previous medical history is very important. Previous medical history, well, such questions you should always judge which answer will be the apt one, because when we will study further about interpretation of radiographs of medically complicated conditions, medical history also plays an important role while establishing a diagnosis. Okay, so for that, um, what happens in this, okay, pertaining to this particular question, C will be the answer. But keep in mind that whenever you are taking a radiograph and if the patient has reported a medical history, definitely it plays a significant role in diagnosis also. Okay, so 12th question, on an image the presence of a double lamina dura indicates what? The answer is D, that is photons at a right angle to the tooth surface. Okay, so that is a fault basically. So 13th one, the gingival margin of the alveolar process appears on a radiograph as a, okay, the 13th is A, radiopaque line. Okay, then 14th, uh, which is the position of the normal alveolar crest. The 14th one, C, not more than 1.5 millimeter from the cemento enamel junction. So answer for 14th question will be C. Coming to 15th question, the radiographic significance of the alveolar crest is to show its position. Okay, basically 15 it is the B, to rule out any periapical changes or periodontal changes. Okay, so 15th answer is B. 16th, the length of the alveolar bone in a particular region depends upon which factor? That is, answer will be C, distance between the teeth in question. Okay, 17th one, disease. That is B, rounding of junctions with lamina dura. Okay, there is no angulation, it is rounded. There is a bone loss, so it is indicating more of periodontal disease over there. Okay, so 18th one, which best explains the radiographic appearance of the periodontal ligament? The answer is C, that is composed primarily of collagen. 19th one, when appraising the patient's periodontal health, the dental practitioner should examine the images and compare all except one. Which one is the exception? 19th answer is C. Symmetry, yes. Trabecular size, yes. Trabecular distribution, yes. Pulp chamber and periodontal health doesn't make sense, right? So 19th, the option is C. 20th question, which structure appears as a thin radiolucent line in the midline between the two portions of the premaxilla? Okay, so that is answer will be A, that is median suture, okay, the thin radiolucent line in the midline. So you should immediately remember that what falls in that area, what is the radiolucent structure which falls in the area, that is median suture. So that is called as, so for 20th answer will be A. Coming to 21st question, the radiographic borders, the radiopaque borders of the intermaxillary suture are formed by, the answer is B, cortical bone of the maxilla. Okay, so two maxillary bone are attaching, and then you have the intermaxillary suture is formed in that place. Okay, so 21st answer will be B. 22nd question, the radiolucent area superior to the apices of the maxillary central incisor is called, what is it called? Okay, so the answer is D, that is inferior portion of nasal cavity or the nasal fossa. Okay, immediately above maxillary central, what is the radiolucent structure over there? The first one what we learnt, nasal fossa. Fine. Okay. 23rd question. Which reason best explains why the image shadow of the septum may appear wider than expected? Okay, the answer is C. Superimposition of septal cartilage and vomer bone. Because X-rays are two-dimensional representation of a three-dimensional structure, there are many superimpositions and many positional difference will come. So you should always first remember what exactly exists in that particular area and what you can differentiate. Okay, so 23rd answer will be C. 24th, the nasal cavity or the floor of the nasal cavity may be visible in all maxillary images except one. Which one is the exception? 24th, the answer is A. Where molar region, the nose doesn't exist 50th. The insicive foramen, okay? C. That is nasopalatal canal. Okay, so 25th answer is C. 25th answer is C. 26th question, if a diffuse radiolucent area is visible near the apex of the lateral incisor, but the lamina dura around the incisor is intact, then which is the most likely over there? Option is B, lateral fossa. Okay, 26B. 27th question, which soft tissue is frequently visible in images of the maxillary central and lateral incisors? That is tip of nose A. Okay. 28th question. Which radiolucent normal anatomical structure is occasionally visible when steep vertical angulation is used to expose a maxillary canine image? What happens over there? That is nasolacrimal duct or the canal is formed. Okay, so 28th answer is D. 29th, which structures form an inverted Y shape in canine images? They are C. That is floor of the sinus and nasal cavity, inverted Y line of Ennis, that is called. Okay, coming to 30th question. Which circumstance could result in extension of the floor of sinus to the alveolar ridge? The answer is C. Loss of posterior teeth. When there is no posterior teeth, such a instance can occur. So 30th question option is C. 31st question, which condition can mimic tooth pain? Okay, that is B, sinus infection. Definitely, if there is a problem in the maxillary sinus and patient is complaining that I have pain in the upper left or right back teeth region, what other than tooth pain, other than dental pathology, what else you need to remember is that there is a presence of the sinus. So any problem in the sinus, definitely the tooth pain the patient will have, or they may experience tooth pain, or they may have the tooth pain. It will mimic a tooth pain, I can say that. Okay, so 31st option is B. 32. Which landmark often appears as a U-shaped radiopaque line? That is D. Zygomatic process. Okay, so which radiopaque, 33rd question, 34th question, which landmark appears as a radiolucent line in babies yet is not apparent in children older than 1 year of age? The option will be C, that is mandibular symphysis. Okay, that is when the bones fuse and a lot of growth take place. So they appear in very young babies, but in children older than 1 year, they do not. Okay, so because it's fused. So 34 answer is C. 35th. Which bony protuberance is located slightly above the mandibular inferior border? Option is B, that is genial tubercles. 36th. Which foramen is located in the region of the genial tubercles? Answer is C, that is lingual foramen, okay, on the lingual side. 37th question. The mandibular canal terminates anteriorly at the A, that is mental foramen. 38th question. Which radiolucent landmark is clearly visible on maxillary occlusal projections? What is it? That is D. Nasolacrimal foramen. We shall see in the consecutive lessons all these things. So, which causes the slightly radiopaque contrast superimposed on the maxillary premolar teeth and alveolar process? The option is B, that is nasolabial fold. So coming to 40th question, which landmark occasionally appears as radiopaque lines curving forward and upward towards the mandibular midline? Option is A, that is mental ridge. Okay. Then 41st question, which structure appears as radiolucent vertical lines? That is C. Nutrient canals. The 42nd question, the bony depression located on the lingual surface of the mandible accommodates the, that is submandibular gland. Okay. Submandibular fossa is there. This is the submandibular fossa. They accommodate what? The submandibular salivary gland is situated there. So option for 42nd question is C. 43rd question, the external oblique ridge is an attachment structure for which muscle? Okay, so this is buccinator muscle, C option. 44th question, which action remedies the superimposition of a dark linear shadow bounded by thin radiopaque borders on the mandibular molars? The option is C, that is changing of the vertical angulation. Okay, 45th. Which action will prevent the opacity of the coronoid process from obscuring the structures in the maxillary molar region? That is C. Have patient minimally opening the mouth. Okay. Because if the patient opens the mouth very wide, what happens? Coronoid process picture is formed on the maxillary radiograph. So we don't want the coronoid process over there, then the patient mouth opening should be slightly lesser. Okay. Next, 46th question. Which restoration appears as the most radiopaque with irregular margins? Option is A. Amalgam, silver amalgam restorations. 47th. In which maxillary periapical image is part of the mandible most likely to appear? That is A. Molar. Okay. How? That is because of either you can see the coronoid process or even some part of the ramus. Depends on which view you're taking. Okay. So 48th question. Which added material aids in distinguishing a composite restoration from dental caries? That is C. Barium glass. Then 49th. Which is a radiopaque rubber-like material used in endodontic therapy? That is B. Gutta percha, which is the um, filling material of chocolate. The last question for today. Which characteristic is most influential in determining the element's radiographic appearance? Answer is D. That is atomic number. Go back to your radiation physics, you will understand. Higher the atomic number, everything changes, right? From the photoelectric absorption, from the um, amount of radiograph which is absorbed, and then what happens during the developing stage and everything. So, a radiographic appearance of a particular element or a particular part, it all depends on the atomic number of what is there, and that determines how the x-ray is going to give an image of that particular area. Okay, so that completes today's normal anatomical landmarks intraorally. Okay, so our next topic will be intraoral projections. I request you to kindly go through today's topic. Please learn the diagrams and understand. Or if any of you are routinely practicing um, radiographic techniques, then please you can refer to any of the radiographs you have taken and identify that what is the region of the mandible, what is the region of the of the radiograph you have taken and what are the normal anatomical landmarks you have taken. Next topic will be on intraoral projections, wherein we will be dealing with IOPA, bite wing, and occlusal. Okay, different type of projections, advantages and disadvantages, indications of each, and what are the things we are able to visualize in each. Okay, timing will be notified to you. Till then, keep studying. Thank you so much.